everyone. Welcome to a new episode of Retina Around the World. As we have mentioned, we are roaming Mother Earth for interviews with prominent and pioneers in the vitreoretinal field of surgery and medicine. Today, we are landing in Asia, in Saudi Arabia, where we are going to meet a world-renowned Dr. Abdullah Qahtani from Saudi Arabia. Dr. Abdullah is a well-known vitreoretinal surgeon who has built his career in Jeddah, Saudi Arabia. And we are pleased to have him with us today in Retina Around the World. Hello, Dr. Abdullah.
Hello, Dr. Amr. It's a great pleasure to be part of this event, and thank you for the invitation.
Dr. Abdullah, we would like to start by having some familiarization to our audience. We need to ask you some personal questions. Where did you take your education, medical education?
For social part, actually, I born in Jeddah. Then my father traveling a lot, and growing in the north, originally from the south. Studying a little bit in the center and doing my medical college in the eastern. So this is where I did my general medical college. Then I get a scholarship from the government to do my residency in Paris, in France. Then I did there also my fellowship. Then I add 1 year fellowship with Karl Klaus in Belgium. So it was a little bit traveling, let's say.
Yeah. So this means that we should have this interview in French and not in English.
Well, it's up to you.
Yeah. No, not everybody is going to be pleased with this. Okay. How did you turn to find interest in vitreoretinal surgery? How did you become an ophthalmologist from the start?
Finishing my tertiary school, there was a little bit two choices for me, either engineering or medicine, no other choice. So my father was pushing for medicine, my mother was pushing for engineering. And I was not bad in engineering. I represent the kingdom in Arabic physics exam at the tertiary school. So when I went to medical college, I found ophthalmology is more close to physics, so it's like a combination. You know, we have refraction, optics, some parameters in the machines, in vitreoretinal. So I think this is make me not far away from I am already has an interest in.
Yeah, well, this is one of the wonders of ophthalmology, because you're actually using your mind, your imagination, having some form of imagination, and enjoying the learning and the use of physics. Dr. Abdullah, can you tell us about your family, your children?
Yeah, I'm married. I have 6 children, 4 sons and 2 daughters. And I think this is my best prize in life.
Exactly.
All of them healthy and doing well, alhamdulillah.
Alhamdulillah. Any plans for them to go for engineering?
Well, this is their own choice, actually. I'm not going to push anyone for anything, and we love them as they are,
exactly.
Not for something else.
Exactly. What are your hobbies, Dr. Abdullah? I can see that you certainly have some hobbies. What are the hobbies that you prefer to do in your leisure time?
Well, if we have a time, I'm in love with photography. Actually, I have. My father has been in United States in the 80s, and he was studying electronic there, and he takes some courses for photography at that time. So I think he spread it to us. So I'm having some photography interest.
Fundus photography, Dr. Abdullah?
General photography, actually,
yes,
more or less.
Yes. Dr. Abdullah, you told us that you have been cruising between Paris and Belgium.
True.
what actually did you learn, or what is the experience you gained studying over there?
Well, I did my residency in Paris, and I did also a fellowship in ocular oncology in Institut Curie with Madame Pascal Massin and Madame Nathalie Cassou. Also, I did retina training with Ramin Tadayuni and Alain Goodrick. Pascal Massin also was there in Lariboisière Hospital, which is concerned more for retina in Paris. Then I take 1 year also surgical fellowship with Karl Klaus in Belgium, in Antwerp, actually. And, you know, Antwerp was the place for Jivanovic before, then Karl Klaus get all the heritage there. And it was very, very fruitful year that I spent it with him, actually. So my most of the time, because my wife was staying in Paris, and I was going to Belgium almost every week, coming back at the weekend only, because she was pregnant at that time, and her assurance doesn't cover her in Belgium, only in Paris. So she stayed there, and because of the School of the Children for that year, and because we have already our own home there, and by train it's like 1 hour or something, and so it's not far away. By car maybe 3 hours maximum. So every weekend I go between, really it's a physical travel between Belgium and France almost every week. And to be honest, it was very fruitful trip that I take it every week, because there was some audible book that you just turn it on and you listen till you arrive. So I finish a lot of book on driving, actually, more than on reading during my fellowship.
So you actually gained benefit from the time of the trip to invest and your knowledge in whatever subjects did you?
It's general subjects, actually, economics, geopolitics, a lot of things, history, and I think it was one of the best idea that I take it and I apply it at that time.
Yeah, this is good use of time, I think. What type of history do you find interesting?
Well, of course, Arabic history is one of the best that may attract me, but definitely Europe is a very rich in their history, which is amazing how you can read about them and see the building in front of you. It's make you feel that you will be able to live in that time. And I think this was my chance at that age, that I passed this experience.
Yeah, it gives you some form of orientation about the culture and civilization that you were actually living in. What's your impression about whatever you learned? What's your impression about the professorialship of the people that you have spent time with? Do you think that they actually left an imprint on your personality?
I think everybody you meet it in your life, he will have some imprint on you. And I think this is the advantage of being different, because since we are different, we learn from each other, we accept some criteria from each other, and we understand how is the point of view is different in that, which is something I think good. It's not something bad to meet some different people and different culture. This is how you build your own knowledge of life generally.
Okay.
Yeah, but definitely since I was child, I was planning for this scholarship. I was putting in my mind to go abroad first for scholar and see how it's life. Number two, to look for a good specialty that I can spend my life with.
Okay. What was the most important virtue in one of your mentors that actually led the way or enlightened you through your career?
I have something from Alain Goodrick. He advised me at the end of my training that I shouldn't look for money. He said, just look for science, money will come following.
Exactly.
And this was one of the best advice, and I learn a lot from his personality in the clinics. Professor Karl Klaus, also in Belgium, he teach me how how hard work mean actually. He was doing a huge number of vitrectomy per day, which is a dream for any vitreoretinal, in my opinion.
Dr. Abdallah, what's your impression about ophthalmology in the Middle East? Do you think that we have gone so far, and this is for sure, in reaching a very advanced level, thanks to the advances in technology and, of course, to the scientific minds we have? What do you think that we still need in ophthalmology in the Middle East?
As you said, I think the ophthalmology in the Middle East have already passed a very, very advanced level, actually, in many countries, in Egypt, Saudi Arabia, Kuwait, Jordanian, and other Arab countries, Emirat also. So I think cooperation between those society in building an Arabic bank of data, bank of experience, bank of lectures could be a very, very good source of information for the young generation that is coming. And I think this data could be a very good heritage that we can give it to the generation to come.
Exactly. And I really think that we have an enormous and vast amount of data and knowledges and experiences and different cases that can actually facilitate this cooperation. What do you actually see for the future in vitreoretinal surgery?
Well, it's already has been passing a very advanced level. You remember the 20 gauge, 23 gauge, 25, 27, and the 3D now microscope after the OCT built-in microscope. There is a lot of advanced technically, and I think, as usual, as most of the medicine, the physics advance is faster than the clinical application of this physical knowledge.
Yeah, this is Dr. Abdallah, the engineer, speaking now. You know,
which is, I think, is very good for us, because since the physics is beyond us, we have a space of work for us, because I think physics is behind most of the humanitarian advancement. And as you know the vitrectomy, there is a fluid coming in the eye, fluid coming outside the eye, cutter speed, cutter gauge, and all of those is a very physics application. The machine, what I think, in my opinion, the advancement more in the machine itself, in light visualization, but I'm not sure about the pump of the machine, for example. Most of the machine doesn't pass 650 as a vacuum. And I'm not sure if the probe become smaller and smaller. I think the vacuum pump should be more stronger, which is, I haven't seen it yet in the machines in the market. So I think in the future, making this advancement in the machine itself, a core advancement of the machine, a body advancement of the pump of the machine itself, rather than of the periphery like lights or vitrectomy probes or infusion line. Would be coming, hopefully.
Yeah, I think the privilege in ophthalmology that it is an industry-backed science. You are having an industry to back you up, and this is going to guarantee continued progression and development throughout the time. Because once you're having an industry that is backing you up, you're having competition between different companies. I think this is the main advantage, one of the main advantages we do have in ophthalmology. Well, this brings us to the end of the first part. We are going to have a break and come back to you with Dr. Abdallah's talk. Thank you.
Thank you.
Hello, everybody, again. Now we are back from our break. we're getting ready to attend Dr. Abdallah's interesting lecture about trauma cases and their surgical managements. Dr. Abdallah, please go ahead.
Thank you, Dr. Amr, and thank you for this invitation. Hello, everyone. This is Abdallah Al-Qahtani, and it's a great pleasure to be part of this meeting. So I'm going to talk about the trauma cases management that we face in King Abdulaziz Medical City. And we will start with an old trauma that patient came to us after 20 years of trauma. So there was a fibrotic attachment and calcification of the crystalline attaching to the anterior cornea. So we decided to do a prosthetic keratoplasty and PVD for this patient. So after preparing the cornea, putting visco is very helpful because it stabilizes the anterior chamber. Sometimes you keep the infusion or you remove it, it's up to you, just to make sure not to open it without careful attention. It can cause an expulsive hemorrhage or expulsive movement of the eye. And retinal detachment. Viscid Caesar is very helpful sometimes to cut this fibrotic attachment to the cornea. With anterior synechiae, dissecting is by forceps. Sometimes you may need to use the vitrectomy. If you need also to do a delivery in an open sky technique, you can do it. And as you will see, the calcified material, it's impossible to remove it by the vitrectomy or the phaco. Completing the vitrectomy in open sky, if it's possible. Putting visco is very helpful in stabilizing the eye from time to time. Then you remove any remnant with the Caesar and put the temporary keratoplasty or the prosthetic keratoplasty. This is the 9mm temporary keratoplasty, and I always advise to use the, sorry, this is the 7mm, and I like the 7. There is two types of it, 7 and 8. 7 is very used frequently because it's give a remnant of the cornea that allow you to suture the graft easily. So completing the vitrectomy. And unfortunately, as you see, this is because it's a chronic retinal trauma or chronic trauma. There is a pigmentation everywhere. Putting Kenacort is very helpful to remove any remnant of the vitreous. After that, you suture the graft in opposing technique. And as you may know, we don't do the complete go-through suture. It's only partial thickness suture, so we don't penetrate the endothelium. Opposing technique is very helpful to avoid any decentralization and completing the suturing of the graft till you finish. And this patient has just a little bit improvement from light perception to hand motion, and the reason is the retinal condition after this old trauma. So it's always better to operate the patient as soon as possible rather than wait years just to operate those cases. Second case is a Marfan syndrome that has a dropped crystalline because of the trauma. And as you see in this patient, it's not very well dilated, and we expect that in pediatrics sometimes, or in an old trauma. So we do dissecting of the conjunctiva in both sides. We do the same in the other side also. Iris hooks is helpful to widen the iris. This is the crystalline over the retina, and because it's a child and a soft crystalline, we don't use the fragmentome. We believe that vitrectomy could be enough for those cases. So after removing the vitreous, Kenacort is, as we said, is very helpful. Grasping the crystalline, and with setting of high vacuum and low cut rate, you can eat this crystalline with the vitrectomy itself. Putting the PFCL is very helpful in protecting the retina from multiple falling of the crystalline. As you would see here, removing the crystalline is easy. After that, then we remove the PFCL, trying to make sure with Kenacort there is no remnant of the cortex, as in those cases because of the crystalline over the retina. Sometimes you don't do complete PVD, so we need to check it later. And as you see in this case, removing the cortex after removing the crystalline. Endolaser, then preparing the case for sclerofixation IOL. We do 2 sclerotomy on each side. One is distal from me, which is the wider, and one is just narrower to me, which is the needle of the suture itself. Because when I want to perrate the knot, I don't forget that it's the distal, which is the wide. So I rotate the knot inside the eye through the distal sclerotomy. Putting the suture through the haptics. As you see, this type of lens has a ring in the haptics. Then back through the needle. And widening the corneal incision with the corneal scissor and introducing the IOL inside the eye. After centralization and pulling both sides of the thread of the suture, you can tie the suture. So as you see in this case, rotating is distal to me because the distal sclerotomy is the wider by a wider needle. Do the same in the other side, removing the iris hooks and the trochus. Make sure there is no leak through the sclerotomy and removing the trochus and filling the eye with gas or with air if you like. Then the case is ended. Iris trauma also in this case, in which the patient has a corneal laceration, suture 1 week back, then bring second week when the cornea become a little bit clearer, and decide to remove to suture the iris. The incision is inferior temporal, which is at the cut of the iris, and this is the left eye, so inferior temporal is a difficult positioning to operate. MTS forceps, this is very helpful. Curved forceps or straight forceps. Always I prefer the curved because it gives you a good angulation and good manipulation. Putting the needle through the edge of the iris on both sides and using the incision of the cornea that you do to pull the thread through, cutting the needle after that and tying the eye. So we are pulling the thread through that corneal incision. Then after tying we can push back the iris inside the eye and wash the visco that has been introduced. Sometimes because of the manipulation, you will find the iris is not very regular, and don't worry about that. As you see in post-op, the iris become very round and centralized. It just because of the manipulation and the visco was inside the eye, it gives you this distortion condition. This is the last case. It's a trauma of a patient losing his iris and crystalline at the same time. So we decide to do iris prosthesis with the optic part. So the patient doesn't need to have an scleral fixation IOL. So this is a scleral fixation IOL and iris prosthesis at the same time. Some people complain of the pigment dispersion and the uveitis. We didn't see it in this case, but we are following him up. So Gore-Tex suture is very helpful, and it's give you a good stabilization. And as we see it in the previous case, it's the same like the scleral fixation that we put it before, suturing the cornea and suturing the conjunctiva with a Vicryl suture. And this is the end. And thank you for listening, and I will be happy for any question.
Thank you so much for such an eloquent and refined type of surgery, Dr. Abdullah. We really enjoyed watching this dreadful cases getting good results as you successfully managed to get. Do you usually resort for scleral fixation with this technique, or do you do Yamani technique also?
This is a very good question. As you know, it's not every IOL fit for Yamani. You need crumpling haptic that can be crumpled by the heat. And this is only, I think, available in thickness IOL and Zeiss type. I think there is another third coming to our market, Saudi Arabia, which is the Avanci. But apart from those three, it doesn't work. We have tried on some types of lens that has an acrylic haptic, which is doesn't get really reacted after the heat application. But definitely Yamani technique is one of the best choices in those cases, definitely.
Don't you get afraid that you might have some form of infection, long-term infection, due to the protruded haptic, especially if conjunctival erosion develops in these patients?
Well, to be honest, theoretically, there is always an erosion
exactly.
in the haptics risk, but we haven't seen it much, and I haven't seen any infection post those cases. I think with a good covering of the tenon and conjunctiva, I think this is could seed it properly. Some people like to keep the bulging bark of the haptics after the heat application inside the tunnel and not just protruded over the sclera and under the conjunctiva. So when you push it to be inside the tunnel rather than under the conjunctiva, I think this is one of the reasons that erosion gets minimized.
Okay, for the Marfan's case that you have just showed us, did you subtract some form of percentage from the IOL calculation that you managed to do because he was a child?
This is a very good question. We used the other eye to calculate the one for the right, and I think.
How old was the patient?
12 years. She's a female.
Oh, so you didn't need to deduct any 10% or 20% from the biometry. You just put her the same.
You know, when you put it in the scale in the sulcus form, you don't deduct a lot of power like when you put it in the anterior chamber. So we calculate it as if it was in the capsule, actually.
Okay. I saw you do some PRP over there. Why was this laser done?
This is a very good question. Actually, I'm a fan of laser after most of my vitrectomy. So I would do in most of them a laser for most of the vitrectomy that I'm doing. I wouldn't regret if I do laser and something happen, I will regret when something happened if I didn't do laser.
So you go for 360 degrees laser, Baraj?
On the periphery,
Yeah.
small ring, if the patient is not diabetic. Otherwise, I will consider a PRP form of endolaser.
No, can you describe again?
If, I divide the patient into two patients. One is diabetic.
Yeah.
So those I will do a real PRP.
Okay, so it's a chance for them.
And those who is not diabetic, so they doesn't need the peripheral laserization. So I just do a 3 ring of laser in the periphery just to keep
3 rows, you mean, of laser in the periphery,
to keep the maximum visual field for them.
Well, this is a debatable point.
It
that
is.
Everybody,
yes,
everybody would say, why
matter,
should you laser a normal retina? And somebody else, and I was one of them till recently, I would say that this would grant me a good night's sleep if I did this in a vitrectomy. But I think that still it is a debatable point. If we open up at this point for discussion, I think it's going to be a very long discussion. Something else, Dr. Abdallah, and I would like to, when you did this vitrectomy for the dropped crystalline lens, you actually injected perfluorocarbon liquid on this. Do you usually resort to PFC in all your cases, or you can just do it without?
No, it depends on the case itself, actually. If I think I'm going to drop it many times, I will put PFCL. Otherwise, if it's just a piece of cortex remnant referred from a cataract complicated surgery, I think sometimes you do need to put the PFCL. So it depends on the case itself.
Okay. You resort to using triamcinolone in all of your vitrectomy cases?
Well, triamcinolone is a must. I do it for every vitrectomy, and I do it actually 2 times in most of my cases, just to make sure that I clear all the vitreous. You know, there is a phrase by Jovanovic, vitrectomy is done when all the vitreous is gone. Exactly.
Well, there is a phrase that I actually invented: vitrectomy is the surgery of peel. Okay, you will have to peel in layers, and I really agree totally with you on the use of triamcinolone. I use triamcinolone in all of my cases, but sometimes in diabetics with vitreous cases, I injected triamcinolone up to 7 times, and I still found posterior hyaloid shining through the surgery. The other issue is when you resorted in your first case to a keratoprosthesis, you mentioned that you used the 9mm, which is actually not the common size to be used by most of our surgeons. Why did you resort to the 9mm keratoprosthesis?
Well, 9 and 10 is usually used, but when I'm afraid from manipulating the knot itself or bury it down, I prefer to have wider thread rather than a fragile small thread. But
what number of thread?
It's a Prolene. It's a Prolene 10.
Prolene 9O?
9O or 10O, whatever you have in the OR.
Okay, but why did you actually resort to the wider prosthesis size?
If you talk about the corneal prosthesis,
yes.
10 will be more than enough. If you talk about sclering the IOL, scleral fixation IOL.
No. I'm talking about the corneal prosthesis.
Yeah, the cornea is always 10. It's always 10, which is more than enough, actually.
Okay. Dr. Abdallah, what is your preferred practice in a patient with traumatic aniridia?
As I show one of the cases with the iris prosthesis and implant, there is 2 types. Either you have it as a separate iris prosthesis, which is silicone material, came with 2 types, either personalized or ready-made, which has, I think, 3 color. And I think it's a German company who
exactly
manufacture it. And the other type is to have it with the lens itself, as I show. And this is an acrylic material. People, as you know, afraid from the pigment dispersion and the uveitis after that. I haven't seen the glaucoma, actually, But what's bothered me in those cases is the iris pigmented uveitis. As you know, if you decide to take the iris process alone without the implant of the optical implant in it, it's a little bit flexible, and when you suture it, sometimes this is maybe more associated with glaucoma rather than the one came with the lens itself, and you suture it properly and you hold it in its place in the sulcus. I think this has less association with the glaucoma rather than the movable
the issue is that in the first type that you've mentioned, the German type, you can actually split it and suture some pieces of it to iris gaps and defects. But totally agree with the uveitic glaucoma and all the uveitis. This brings us to the end of our episode. Hope you enjoyed it. I really did enjoy the company of Dr. Abdallah Qahtani from Saudi Arabia. It was a real pleasure to have him with us. He actually enriched our talk, and it's very good for us to be always sharing and communicating. And I wish you all a happy Ramadan. I'm going to leave the floor to Dr. Abdallah to finish up his talk, and thank you so much.
Thank you, dear, for this invitation and introduction. It was a great pleasure to see you, to participate with this event, and hopefully we keep those activity as long as we can.